This video will discuss the assessment and management of juvenile osteochondritis dissecans of the knee. In the sports physiotherapy world, we're frequently called upon to assess and treat athletes of all ages. This may range from young children through to nonagenarian masters athletes. Sports physiotherapists would know when dealing with young athletes missing a career-ending diagnosis can be unforgivable. One such diagnosis is juvenile osteochondritis dissecans of the knee, a condition that commonly affects athletic children and one that if left unchecked could jeopardise the integrity of their knee. Accurate and timely diagnosis, followed by appropriate management, is essential when dealing with juvenile osteochondritis dissecans. A little bit of background information on the condition. Osteochondritis dissecans is an acquired, potentially reversible, idiopathic lesion of the subchondral bone, which results in delamination and sequestration, with or without articular involvement and instability. The condition has an incidence of 15 to 29 per 100,000, and it is seen mostly in children, and growing participation by children in competitive sports at younger ages has meant that the mean age of onset of osteochondritis dissecans is decreasing. Males are predominantly affected at a ratio of 5 to 3, and the condition is seen bilaterally in up to 25% of individuals. If left unchecked, this condition may jeopardise the joint and lead to early onset arthritis. Osteochondritis dissecans may in theory affect any joint. 65 to 75% of cases are seen in the knee, 75% of which are found to affect the posterolateral aspect of the medial femoral condyle. There have been many postulated causes of OCD, including inflammation, genetics, ischemia, ossification, and repeated microtrauma. In terms of any etiology, there remains insufficient evidence to conclusively support any of these causes. The most widely accepted cause is the influence of repeated microtrauma. Repetitive trauma induces a stress reaction, resulting in a stress fracture within the underlying subchondral bone. When and if this loading persists, thus exceeding the ability of the subchondral bone to heal, necrosis of the fragment may occur, leading to fragment dissection, separation, and finally non-union. In terms of classification of juvenile osteochondritis dissecans of the knee, it mostly affects children, however it can also affect adolescents and even adults. Osteochondritis dissecans can be classified by the maturation status of the distal femoral physis. It is classified as juvenile in those with a wide open physis, as adolescent in those with a closing physis, and as adult osteochondritis dissecans in those with a closed physis. There are many different classification systems that are used for juvenile osteochondritis dissecans. Two popular classification or staging systems are shown below. The first is presented by Hefty et al. In 1999 and is based on MRI findings. They suggest stage 1 is a small change without clear margins of fragment. Stage 2, there is an osteochondral fragment with clear margins but without fluid between the fragment and underlying bone. In stage 3, fluid is visible partially between the fragment and underlying bone. In stage 4, fluid is completely surrounding the fragment, but the fragment is in situ. And in stage 5, the fragment has become completely detached and displaced, and there is a loose body present. The second classification is Gould's, put forward in 1982, and it's based on findings at arthroscopic assessment. They suggest stage 1 shows intact lesions, stage 2 are lesions showing signs of early separation, stage 3 are partially detached lesions, and stage 4 there are craters with loose bodies. The stage of osteochondritis dissecans will likely affect your subjective and objective findings and also the course of management undertaken. In terms of subjective assessment, the patient may report the following: pain or discomfort anteromedial to the patella. You've got to think of the classic OCD lesion on the medial femoral condyle. Pain is frequently non-specific and poorly localized. Symptoms are exacerbated by exercise, particularly when climbing hills or stairs. The patient rarely reports a specific mechanism. The patient may report swelling and stiffness. And mechanical symptoms, such as locking or catching, are common in later stage osteochondritis dissecans, and they indicate unstable, loose fragments. Your objective assessment may uncover the following information. On observation, an effusion may be visible, and quadriceps wasting may suggest longer presence of symptoms. There may be an antalgic gait present, with tibial external rotation to try and unload the medial condyle. Palpation shows maximal tenderness over the anteromedial aspect of the knee with varying amounts of knee flexion. This is called a positive Axhausen sign. Wilson's sign is pain with internal rotation of the tibia. Unfortunately, this test lacks sensitivity, as 75% of patients with osteochondritis dissecans were found to have a negative result. The swipe test may be useful for the detection of an effusion. Now to imaging for osteochondritis dissecans. Radiographic information is essential if there is a clinical suspicion of osteochondritis dissecans. It is important for confirmation of diagnosis, lesion characterization, predicting prognosis, making informed management decisions, and assessing the recovery and healing during treatment. In terms of X-ray, plain radiographs can be used in both children and adults to rule out other bony injury, evaluate skeletal maturity, characterize and localize the OCD lesion, and indicate its age. The following views should be taken: AP, lateral, notch views, and also a skyline if patellar involvement is suspected. Magnetic resonance imaging should be considered as a normal part of the diagnostic evaluation, as it can accurately assess the lesion's size and status, the status of cartilage and subchondral bone, bony edema, and the presence of any loose bodies. In terms of conservative physiotherapy management, there is widespread agreement that initial non-operative management is indicated in juvenile osteochondritis dissecans. Cahill has previously reported that 50% of juvenile OCD lesions will heal within a 10 to 18 month period, provided the physis remains open and patient compliance is maintained. Whilst there is some controversy in the literature regarding immobilization timeframes, there is some consensus on a general 3-phase management protocol. Phase 1, generally between weeks 0 and 6, the knee is immobilized in either a cast or brace, the patient is partial weight bearing with crutches, and in order to progress, the child must be pain-free. Phase 2, generally between weeks 6 and 12, the patient is out of the cast or brace, they are weight bearing as tolerated, and you can commence rehabilitation, which includes knee range of motion and low impact strengthening. At this stage, sports are still restricted. Criteria for progression include clinical and radiographic signs of healing. And the final phase, generally between 3 and 4 months, is a graduated return to loading, including running, jumping, and eventually sports. A complete absence of knee symptoms is required to increase intensity. At this stage, a repeat MRI provides valuable information on lesion healing. Now to the surgical management of osteochondritis dissecans. There are a few indications for surgical management. These are skeletally immature patients with detached or unstable lesions, failure of non-operative management, and in adult patients. The goals of surgical management are maintenance of joint congruity, allowing healing of the junctional subchondral bone, rigid fixation of unstable fragments, and to repair any osteochondral defects. It is important that you are aware of the various options for the surgical management of osteochondritis dissecans. The options include drilling, both antegrade and retrograde, internal fixation, abrasion and microfracture, osteochondral autograft or allograft transplantation, and autologous chondrocyte implantation. As you might expect, there are various indications and success rates for each of these surgeries. Now, the clinical implications and the take-home messages. This is a condition which commonly affects young athletic populations. Clinical diagnosis can be challenging, so you should maintain a high clinical suspicion of this condition. Imaging is an important diagnostic tool and not to be shied away from. In juvenile osteochondritis dissecans, conservative physiotherapy management is the first port of call. There are many surgical options available should conservative management fail. What are your thoughts? Let me know on Facebook and Twitter, and for more information, visit thesportsphysiotherapist.com.